Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as a digital partner for this event hosted by Indian College of Anesthesiologists, and the focus of today's session is CKD and anesthesia. Now, I would like to invite Dr. Jayshree Sood ma'am to proceed with the session. Over to you, ma'am. Thank you.
Thank you, Rimpa. Good evening, everybody.
Good evening.
Good evening, ma'am.
It's my proud privilege to be welcoming all our speakers today for this excellent webinar that we are going to have. And you all know that the ICA is conducting these webinars for the last 5 years. And we are one of the pioneers in the sense who have hosted webinars continuously for 5 years. So that's a big credit, which I think goes to the ICA only because of the faculty who joins us. And today, of course, I'm very proud that for the CKD and anesthesia webinar, the perioperative challenges, cutting edge solutions, we have a very good team, expert team from Rohtak, from the Department of Anesthesiology at the Pandit B.D. Sharma, PGIMS Rohtak. And the moderator for this session is Dr. Susheela Taxak, who you all know is a very senior professor in the specialty, as well as a very senior member of the Indian College of Anesthesiologists. With her is her team, who will be dealing with the various subjects on CKD. So the perioperative challenges and cutting-edge solutions, CKD and anesthesia, I request Dr. Susheela to kindly take over.
Good evening, everyone. Thank you so much, ma'am, that you gave us an opportunity to be a part of this webinar series. So today we are going to talk about CKD, as madam has already told. The speakers for today will be Dr. Sudha Puhal, Dr. Anju Rani, Dr. Mamta Bhardwaj, and Dr. Kirti Kshetrapal. Dr. Mamta and Dr. Kirti, they are the pillars in the renal transplant team of our institute. And Dr. Sudha and Dr. Anju, they are associate professors in our department, and they also actively take part in the care of these patients. The CKD, it impacts all the organ systems. So therefore, it is very important to have a very comprehensive knowledge about the subject so that we can conduct a safe anesthesia and we have a positive outcome. So to start with, we invite Dr. Sudha Puhal, because she will tell us in details about understanding of the pathophysiology of chronic kidney disease. Dr. Sudha.
Thank you. Thank you so much, ma'am. Okay, I'll share. So today I'll be telling classification and pathophysiology of chronic kidney disease. So what is chronic kidney disease? So KDIGO, that is Kidney Disease Improving Global Outcome, has classified chronic kidney disease as abnormality in kidney structure or function persisting for more than 3 months with having various implications on health. So criteria for CKD. Either one of the following should these criteria out of these criteria, either one of the following should be present for the CKD has to be confirmation of CKD. So these are either kidney damage or dysfunction of kidney. So in the kidney damage, these are the few criteria like albuminuria, and that is urine albumin more than 30 mg per 24 hours, or urine albumin to creatinine ratio that should be more than 30 mg per gram. Or if there is any abnormalities in urinary sediments like RBC cast, WBC cast, and various granular cast, or histology or imaging suggestive of kidney damage. or renal tubular acidosis showing various electrolyte disturbances, or is there any history of kidney transplantation, or kidney dysfunction in the form of if estimated GFR is less than 60 ml per minute per 1.73 meter square of body surface area. So, classification of CKD. So, we have classified CKD on the basis of GFR as well as on the albuminuria. So, first we'll see the GFR categories. So, G1. In G1, GFR will be more than 90 ml per minute. That is normal to high. And G2, in G2, it will be 60 to 89 ml. That is mildly decreased. And G3 has been divided into two stages, G3A and G3B. In G3A, it will be 45 to 59 ml, that is mild to moderately decreased. And in G3B, it will be 30 to 44, and that is moderate to severely decreased. And G4, it will be 15 to 29 ml, that is severely decreased. And then at last will be G5, whenever the GFR will be less than 15 ml, that will be kidney failure or end stage renal disease. So in G1 and G2, if there is no evidence of kidney damage, then they will not be called as chronic kidney disease. And albuminuria has been divided into three stages, A1, A2 and A3. So in A1, albumin excretion ratio will be 30 mg per gram, that is normal to mildly increased. And in A2, it will be 30 to 299, and that is moderately increased. And in A3 category, it will be more than 300 mg per gram, and that is severely increased albuminuria. So, when we look at this chart, we can see as the GFR starts declining and as the extent of albuminuria increasing, there is an increased risk of disease progression of CKD. Like this color changes from green to yellow and then orange and then to red. So this color change shows the increased risk of progression of chronic kidney diseases. So next are the causes of CKD. What are the causes of chronic kidney disease? So these causes can be glomerulopathies, they can be tubulointerstitial diseases, and they can be systemic hypertension, polycystic kidney diseases, renal vascular disease, and obstructive uropathy. In glomerulopathies, diabetes mellitus and membranoproliferative nephritis and post-infectious glomerulonephritis, and it can be IgA nephropathy, and it can be SLE, and it can be amyloidosis. And among tubulointerstitial diseases, the causes can be analgesic nephropathy, reflux nephropathy with pyelonephritis, myeloma kidney, and there can be sarcoidosis. So among all of these causes, diabetes mellitus is one of the most common causes of CKD, which is closely followed by systemic vascular hypertension. So now we come to pathogenesis of chronic kidney disease. So as all know, in chronic kidney diseases, there will be reduction in the renal mass that will further cause the reduce in the nephron numbers. So this reduced number, they'll start having adaptive hyperfiltration at the glomerulus, which will further cause increased glomerulopermeability due to the disruption of the barrier at the basement membrane. And there will be increased activity of renin, angiotensin, aldosterone activity. And this increased permeability will further lead to increased filtration of proteins and various macromolecules, which will lead to proteinuria and dyslipidemia. And all of these changes will further cause nephrotoxic inflammation and remodeling of the peritubular tissues in the nephrons, which will further leads to tubulointerstitial fibrosis and secondary focal segmental glomerulosclerosis. And these eventually they led to reduced GFR, reduced urine output, and various systemic complications in the late stages. So now we come to pathophysiological manifestations. So uremic syndrome, it's a constellation of various symptoms of anorexia, nausea, vomiting, pruritus, anemia, fatigue, and coagulopathy. So these various disturbances, they causes due to the dysfunction of mainly three spheres of kidney function. And what are those? And these are, first of all, it is due to accumulation of toxins which normally undergo renal excretion. Second one is loss of other kidney functions like fluid and electrolyte homeostasis and hormonal regulation. And third one is progressive systemic inflammation and its various vascular and nutritional consequences. So we'll discuss in details. First is fluid and electrolyte imbalances. So in kidney function, there will be dysfunction in regulating water homeostasis because of reduced GFR and increased activity of renin-angiotensin-aldosterone system. So this will lead to excessive sodium and water retention, which will further cause volume overload. There will be 10 to 30% increase in extracellular fluid volume, which will further cause chronic volume overload, which will lead to edema, hypertension, and various electrolyte imbalances. So this hypertension will further cause various cardiovascular morbidities and mortalities in CKD patients. And in these patients, they also have impaired concentrating ability of kidney. Whenever there will be any loss of extracellular fluid volume due to various causes, the kidney cannot compensate for these loss, and they are likely to have chances of acute on chronic CKD. Acute on chronic CKD. Next is hyperkalemia. So serum potassium levels, they remain within the normal limits until the GFR reaches to 10% of the normal. After that, the viable remains start having compensatory changes. Like there will be increased aldosterone dependent secretion of potassium in the distal nephron, and there will be augmentation of excretion of potassium in the GI tract. So by these compensatory mechanism, they tries to maintain the potassium within normal limits. But these compensatory changes can be easily overwhelmed in many cases. Like if there is any increased intake of potassium, that may be dietary intake, or that can be intravenous intake. And in cases of hemolysis, and if there is any metabolic acidosis, and due to the intake of certain drugs, which also causes intracellular to extracellular shift of potassium, and due to the transfusion of stored blood. So these conditions, whenever these conditions will be present, they can be easily precipitate the hyperkalemia in patients of chronic kidney diseases. So next is disorders of calcium and phosphate metabolism. So in CKD patients, there will be reduced urinary excretion of phosphorus, and that will lead to hyperphosphatemia. And always also there is a reduced 1-alpha hydroxylase, which will further cause reduced 1,25 dihydroxy vitamin D, and that is the active form of vitamin D. So combination of these two, this reduced form of vitamin D, it will lead to hypocalcemia. So combination of these two, hypocalcemia, hyperphosphatemia, they all lead to increased hyperparathyroid excretion, which will lead to hyperparathyroidism. Along with these changes, these CKD patients also have increased activity of fibroblast growth factor, which will further degrade the calcitriol and further augment this hypocalcemia, hyperphosphatemia, and hyperparathyroidism, which eventually lead to high bone turnover disease, that is bone demineralization and renal osteodystrophy. So next is metabolic acidosis. It is one of the common disturbances found in the CKD patients because there is decreased excretion of H ions and there is less production of ammonia to excrete the adequate quantity of protons to maintain the normal acid-base balance of the body. So there is metabolic acidosis in these patients, and if there is presence of hyperkalemia, it will further depress the ammonia production, and it will further cause metabolic acidosis. Also, there are many abnormalities in regeneration and reabsorption of bicarbs, and there is serum bicarbonate concentration will be less than 22 milliculents per liter. And these metabolic acidosis can easily be aggravated by hypovolemia and hypotension in these patients. So, due to accumulation of various anions of organic acids, this metabolic acidosis will become high anion gap metabolic acidosis. And even the modest degree of presence of metabolic acidosis is associated with the protein catabolism and progression of this CKD. So next are cardiovascular manifestations. These cardiovascular manifestations are the leading cause of morbidity and mortality in CKD patients. So these CKD patients, they have various traditional risk factor as well as another novel risk factor which are specific to CKD for having various cardiovascular abnormalities like left ventricular hypertrophy, dilated myopathy, and arterial disease, and various conduction abnormalities. So what are the traditional risk factors? These are lifestyle factors, hypertension, diabetes, dyslipidemia, and malnutrition. Along with the another risk factor which are specific for CKD, these are uremia, pro-inflammatory milieu, volume overload, disordered mineral metabolism, electrolyte imbalances, anemia, sympathetic hyperactivity, increased activity of RAS, endothelial dysfunction, protein energy wasting, vitamin D deficiency, oxidative stress, and increased amount of fibroblast growth factor 23 along with decreased clotho. So these all factors which are specifically found in CKD, all they leads to increase in various cardiovascular manifestation in these patients. So there will be in these patients, there will be systemic and chronic pro-inflammatory state which contributes to various myocardial, various vascular diseases, which myocardial remodeling processes, and it will lead to accelerated atherosclerosis, dyslipidemia, vascular calcification, which will further augment the myocardial infarction and ischemic heart diseases. And there will be hypervolemia due to sodium and water retention. There will be chronic overload and high cardiac output states due to chronic anemia and arteriovenous fistulas. So they all causes hypervolemia, and this hypervolemia, chronic volume overload along with progressive arterial stiffness and increased activity of RAS, these all will lead to hypertension. So this hypertension along with hypervolemia, they'll all cause left ventricular hypertrophy and dilated cardiomyopathy, which are the leading cause of cardiovascular morbidity and mortality in these patients. Next is these patients are very prone to various cardiac dysrhythmias like metabolic acidosis due to metabolic acidosis, hyperkalemia, and conduction abnormalities due to myocardial fibrosis. Also, they are very prone to have uremic pericarditis, especially in the patients which are not on regular dialysis. There are more chances of having uremic pericarditis. And these patients have abnormal cardiac function which is secondary to myocardial infarction, and they have very high chances of left ventricular hypertrophy, diastolic dysfunction, various cardiomyopathies in combination with salt and water retention and volume overload. So these all together will lead to congestive heart failure and pulmonary edema in the patients of CKD. So next is hematological manifestations. So the patients of CKD, they have chronic anemia, which is of normocytic and normocytic normochromic type of anemia, with having symptoms of fatigue, weakness, decreased exercise tolerance. And what are the causes of these anemia in these patients? There are various causes, like because there is decreased production of erythropoietin in the kidney, and there is diminished red blood cell survival, and there are increased bleeding diastasis, and there is poor GI absorption of iron can be there, as well as due to hyperparathyroidism, there is bone marrow fibrosis, and also there is a loss of blood during hemodialysis, like blood in the dialyzer, and due to repeated sampling of the CKD patients. These all factors will lead to chronic anemia in these patients. So there are certain compensatory changes are there in CKD patients so that the tissue oxygenation may not hamper. And what are these changes? These are increased cardiac output will be there. There will be less viscosity of blood so that the microcirculation can be improved. And there will be increased 2,3-DPG production, which will shift the oxygen dissociation curve to right. And all metabolic acidosis is also there, which also leads to shifting of oxygen dissociation curve to right, so that the tissue oxygen can be maintained. So due to all these compensatory changes, this chronic anemia in CKD patients can be tolerated well easily as compared to the other patients having acute anemia. So next is abnormal hemostasis. So these patients usually have increased bleeding tendencies, bruising, prolonged bleeding from surgical incisions, menorrhagia, GI bleeding, because they have prolonged bleeding time, decreased activity of platelet factor 3, and also they have abnormal platelet aggregation and adhesiveness, and there's impaired prothrombin consumption. So due to all these factors, these patients have increased bleeding tendencies. And interestingly, in CKD patients, they also have greater susceptibility for thromboembolism, especially in the patients which are having highest degree of proteinuria. So next is the manifestation of GI system. So these patients, they can have increased GI bleeding, they can have nausea, vomiting, anorexia, metallic taste, and uremic breath can be there. Next we come to endocrine system. As we have already discussed, there is disturbances in the calcium and phosphate metabolism which leads to hypocalcemia, decreased vitamin D production, and there will be secondary hyperparathyroidism which leads to bone remineralization and renal osteodystrophy. And there will be impaired glucose metabolism, and there will be reduced plasma testosterone levels which leads to various sexual dysfunctions. So, and the next is neuromuscular abnormalities, central nervous system, peripheral nervous system, and autonomic neuropathies, as well as there is abnormalities in the muscle structure and function. So, in early CNS manifestations, these patients, they can have disturbances in memory, they can have disturbances in concentration and sleep, and neuromuscular irritability can be there in the form of hiccups, cramps, and twitching. And in advanced stages, many of the patients, they can have hysterexis, myoclonus, seizures, and coma. And peripheral neuropathies can also be seen in the late stages of these patients. Many patients, they complain of restless leg syndrome. They have ill-defined sensory sensation in the legs and feet, which can be relieved by the movements of legs. And they can have uremic frost, pruritus, and also these patients, they are at high risk for immune suppression and infection. So in the last, this is the diagrammatic presentation of all pathophysiological manifestations of this chronic kidney disease of various organs. So thank you so much.
Thank you, Dr. Sudha, for such an articulate presentation on the subject. We now understand CKD better so that we can, further go ahead with planning our pre-operative plan for these patients. For the next speaker, Dr. Anju Daya. Dr. Anju is an associate professor in the Department of Anesthesiology at PGIMS. She's a very energetic working person, and she has a keen interest on participating in such events. So over to you, Dr. Anju, for preoperative optimization and preparation of CKD patients. Dr. Anju, are you there?
Dr. Anju, you're muted.
Just unmute yourself on your screen. Yeah. Yes.
Thank you, ma'am, for the kind introduction. Good evening, everyone. Preoperative optimization in chronic kidney disease patients is needed because impairment of the renal physiology may result in multiple complications that must be identified and corrected preoperatively. Chronic kidney disease can be associated with excess surgical morbidity, the most important causes of which include acute kidney injury, hyperkalemia, volume overload, and infection. So preoperative optimization is required not only to consider the pre-existing renal dysfunction, but also the potential risk of AKI in the perioperative setting. So goals of the pre-anesthetic preparation and the optimization are to achieve the safe anesthetic and surgical outcome, to prevent any further kidney damage, and to manage comorbidities as much as possible. To achieve these goals, we need to have thorough understanding of the patient's specific condition and surgical procedures. Because CKD patients have higher risk of complications and prolonged hospital or ICU stay, these patients require comprehensive evaluation and optimization in the preoperative period. And to have a perfect optimization and evaluation, we need to adapt to the multidisciplinary approach that involves the nephrologist, surgeon, and of course us as the perioperative physician. While evaluating the patient preoperatively, we need to address the underlying disease which led to CKD, pathophysiological effects of CKD, influence of CKD on the pharmacokinetics of drugs which the patient is either already receiving or likely to receive in the perioperative period, influence of anesthetic agents on the renal function. In the perioperative risk in the CKD patients depends on the type of surgery and whether the surgery is being done on the elective or emergency basis, what is the severity of CKD, how severely the renal function is impaired, and whether the patient is on dialysis or not, level of optimization of the renal dysfunction and of the comorbid conditions. While taking the pre-operative history of the patient, we need to assess the detailed history of underlying disease and its presentation, whether the patient is anuric or oliguric. Are there any symptoms of other system involvement? Functional capacity or effort tolerance to assess the overall health of the patient, whether the patient is having any previous medical or surgical history and history of blood transfusion, if there is any history of previous anesthesia exposure and any complications if occurred, and the medication that the patient has received in the past or is receiving presently. If the patient is currently on dialysis, then we need to ask the type of dialysis, whether it is peritoneal or hemodialysis, site. Duration of dialysis is very important for us because longer the duration, more likely we can have the difficult venous access in the perioperative period. Frequency of dialysis, last hemodialysis, and weight of the patient before and after dialysis. And we need to ask the patient whether he is having any AV fistula or not. While examining the patient on routine general examination, we need to note the weight of the patient and examine the patient for any signs of pallor and signs of fluid overload or depletion. Systemic examination has to be done thoroughly, including all systems, respiratory system, cardiovascular system, neurological system, and endocrine system, including the airway assessment. If the AV fistula is present, then we need to examine its location, duration of fistula, and whether it is functioning or not by the presence of bruit. Are there any signs of infection, ulcer, or tenderness at the fistula site? Now, before asking for the preoperative investigations, here is the brief review of renal function test. Renal function tests are important in the perioperative scenario to monitor the safe and effective dose of drugs that are excreted in the urine. So to classify the renal function test, we have the urine analysis, including its gross and microscopic examination. Then there are certain blood investigations. Then test for the assessment of glomerular function by the clearance test. Clearance of a substance is the volume of plasma that is completely cleared of a substance by the kidney per minute. And it can be assessed by using the endogenous substances like urea or creatinine, or exogenous substances like inulin or radio-labeled EDTA. However, urea and creatinine have their own limitations because they can be affected by the non-renal factors also. In that scenario, calculated creatinine clearance gives the estimated GFR, which is the more accurate measure of GFR. Then there are tests to measure the renal plasma flow, which are measured by the filtration fraction using the agents like para-aminohipurate. Then test for the assessment of tubular functions like glycosuria, proteinuria, urinary excretion of sodium, and urine osmolality. Urine analysis detects the undiagnosed diabetes or UTI in these patients. It also detects the hematuria or abnormal protein loss. Blood urea nitrogen and serum creatinine detects the underlying renal deficiency and the possibility of developing AKI after major surgery. They also influence the choice of drugs that are to be given in the anesthetic management. However, they have their own limitations as already discussed. Then estimated GFR, it not only ensures the correct dose adjustment, but also help to quantify the perioperative risk. AKI in the setting of CKD should prompt an evaluation to identify the precipitating factors. Elective surgery to be postponed till the resolution of AKI. Now the preoperative investigation, before asking any investigation, we should consider or we should ask ourselves whether the result of the test is going to alter our anesthetic management or not, to avoid any unnecessary investigation. For that, routine investigation plus selective preoperative tests are performed, and the extent of investigations depend on the patient's comorbidities and their optimization. Appropriate counseling with the patient is very important so that the patient can implicate both the positive and the negative result of the test and able to give the informed consent. The following investigations are routinely asked in the preoperative period. Complete hemogram, including the HB for the to assess the anemia secondary to CKD, and the coagulopathy test like platelet count, bleeding time, clotting time, and PT-INR are to be asked. Renal function test, including the blood urea nitrogen and serum creatinine. Serum electrolytes like sodium, potassium, calcium, and phosphate are done. Preoperatively, ABG can show acidosis by the pH levels and bicarbonate levels. LFT and urine analysis are routinely done. blood sugar to rule out the diabetes secondary to CKD. Chest X-ray is done, which can show the cardiomegaly, pulmonary edema, or signs of pleural effusion. ECG may show left ventricular hypertrophy, arrhythmias secondary to hyperkalemia or acidosis. 2D echocardiography to be done as and when required. If the patient is on dialysis, then post-dialysis investigations are asked, like hemogram, renal function test, and weight of the patient is to be noted. Now, for the optimization of chronic kidney disease patients, there are no separate guidelines. Cardiac optimization to be done as per standard AHA guidelines. For fluid and electrolyte balance, ensure the adequate hydration of the patient to avoid both the overload and volume depletion by closely monitoring the fluid intake and the output. Manage electrolyte abnormalities like hyperkalemia and hyponatremia. In patients with end-stage renal disease, we need to ensure the adequate dialysis in the preoperative period. Now, for the comorbidities management, mostly the patients are hypertensive secondary to chronic kidney disease. In these patients, target blood pressure before giving the anesthesia is 140/90 if the patient is not having proteinuria. To control the blood pressure, multimodal treatment including the ACE inhibitors, ARBs, as a first-line treatment, and the other drugs that can be used are diuretics, calcium channel blockers, and aldosterone antagonists. These antihypertensive agents are to be continued in the preoperative period. However, there is a confusion regarding the ACE inhibitors, which are usually withheld in the perioperative period to decrease the risk of intraoperative hypotension if the patient is chronically on the ACE inhibitors. However, multiple observational studies have already shown that ACE inhibitors to be stopped either 24 hours before the surgery to reduce the risk of intraoperative hypotension. However, there is a recent article published in British Journal of Anesthesia in May 2024, which shows the results otherwise. They randomized the patients who are chronically on ACE inhibitors or ARBs in two groups. One group has stopped the ACE inhibitors in the preoperative period, and the group 2 in which the ACE inhibitors were continued. They found that patient randomized to the stop group experienced more postoperative hypertension. And in post-hoc analysis, patient randomized to continue group were found to experience less myocardial injury after the surgery than the stop group. This SPACE trial provides important and new reassuring data on the safety of continuing ACE inhibitors and ARBs before major surgeries, challenging the previous beliefs. Now, to address the hematological issues, most patients have anemia secondary to chronic kidney disease. In these patients, target HbA is 10 to 11.5. And to achieve this target, if the surgery is elective kind of surgery, then erythropoietin can be started several weeks before the surgery. Erythropoietin 20 to 50 international unit per kg thrice a week, subcutaneous or intravenous can be given, or darbepoetin 0.45 microgram per kg once a week, subcutaneous or intravenous. Blood transfusion in the perioperative period in patients having anemia secondary to CKD shall be avoided because it might lead to antibody formation that may decrease the future chances of successful renal transplantation. Also, intra transfusion, if has to be given, should be started very cautiously to decrease the risk of volume overload and hyperkalemia. Now, to address the coagulopathy, bleeding time is the most sensitive indicator of platelet dysfunction. The normal range of bleeding time is 2 to 7 minutes. If it is more than 10 to 15 minutes, then there are high chances of hemorrhage. And if the bleeding time is more than 10 to 15 minutes, it is advised to undergo the heparin-free dialysis. However, if heparin is used in the dialysis, then surgery should be done at least after 12 hours of dialysis. Desmopressin can be used to address the coagulopathy in these patients. Hyperkalemia in these patients can be really life-threatening. In patients having acute increase in the potassium level, in these patients, glucose insulin drip or IV bicarbonate causes transient decrease in the potassium levels, but these levels may rebound with time. If the patient is having chronic hyperkalemia, then exchange resins and dialysis can be used as they remove the extra stores of potassium from the body. Now, for the potassium exchange resin, there is a resin used since the old time, sodium polystyrene sulfonate. However, it has some side effects like colonic necrosis and hypomagnesemia. Nowadays, there are new exchange resins like Pathophysiology, Sorbitex calcium, and sodium zirconium cyclosilicate. In these resins, the sodium-containing resins have a side effect of causing increased blood pressure and edema due to sodium content. The only known sodium-containing resin is Pathophysiology, Sorbitex calcium. We must provide the adequate nutritional support to the CKD patients with modest protein restriction. Overly restriction may lead to malnutrition and its complications. Daily protein intake shall be restricted to 0.6 gram per kg. Vitamin D supplementation can be advised, and phosphate binders can be used to manage the raised phosphate level in these patients. Now, cardiovascular disease is the major complication and the leading cause of death in patients with CKD. Both cardiovascular disease and chronic kidney disease share the risk factors like diabetes mellitus and hypertension. For the risk stratification in patients with cardiovascular disease, RCRI, that is Revised Cardiac Risk Index, incorporates a 1 point allotted to serum creatinine level of more than 2 milligram per deciliter. However, effectiveness of RCRI in predicting the cardiovascular risk in CKD patient is being questioned because of the use of serum creatinine and the different patient profile. Nowadays, role of estimated GFR is being explored to be included as a parameter in the RCRI. If the patient is having edema, CCF, congestive cardiac failure, or pulmonary congestion, and patient who are responsive to the diuretic therapy, these require the further cardiovascular evaluation. However, the patients with advanced CKD and with diuretic resistance with progressive edema, preoperative dialysis is recommended. If the patient is already on dialysis, then we need to determine the dialysis need, adequacy, and any complication if there. If the patient is on hemodialysis, then patient requires the preoperative dialysis a day prior or within 24 hours before the surgery to reduce the risk of volume overload, hyperkalemia, and excessive bleeding. And surgery shall be started after a gap of at least 4 to 6 hours after dialysis. However, if the patient is having the high risk of hemorrhage, then at least 12 hours shall be elapsed between the dialysis and the start of surgery. If the patient is on peritoneal dialysis and undergoing abdominal surgery, then should be switched to the hemodialysis till wound healing is complete. Other than these optimization, aspiration prophylaxis is recommended by proton pump inhibitors or H2 receptor antagonist, NPO to be kept as per standard guidelines, antibiotic prophylaxis with dose adjustment for some antibiotics like aminoglycoside, acyclovir, and amphotericin, which are excreted by the kidney. NSAIDs can be avoided in the perioperative period. Now, these are my key points. Thank you very much.
Thank you, Dr. Anju, for such a detailed view of the preoperative preparation. We all know that chronic kidney disease is a very prevalent disease, and I think 2017, one of the articles in BJA said that it was the prevalence was about 9%, and there are many who are not diagnosed of the disease, and the disease incidence is going on increasing, and this is around the 12th most common cause of mortality in patients. So thank you so much for making us understand about how to prepare these patients when they come to present to us for a surgery. And now with this knowledge with us, I'm sure our next speaker, Dr. Mamta, she will be able to tell us more about how to individualize the planning technique for these patients and how to be proactive in avoiding any complications that might occur and how to dose adjust our things. So next speaker is Dr. Mamta Bhardwaj. Dr. Mamta Bhardwaj is a professor in the department, and she is also one of the, along with Dr. Kirti, she is a key professional, I told you, the renal transplant program in the institute. Dr. Mamta, can we have your slides?
Yeah, thank
Dr.
you so much.
Mamta is also a BLS and ACLS instructor, and she's into lots of research writing. So welcome you, Dr. Mamta, to present on the intraoperative management of the patients.
Thank you so much, ma'am. I will just share my screen. At the outset, I will thank ICA for giving us the platform to speak on this, for giving us the opportunity to speak on this platform. Are my screen visible?
Yes, yes.
Okay. So we all know, as ma'am said, end-stage CKD progressing to end-stage kidney disease is a growing problem. These patients come to us not only for the surgeries related to the kidney, like kidney transplant, parathyroidectomy, and the vascular procedures, but they also come to us for the procedures not related to the kidney. So I will be talking on these points, like patient is come for elective emergency surgery, few points on vascular access, then intraoperative anesthetic management, concerns like fluid and glucose management, and the post-op analgesia. So whenever these patients come for emergency surgery, three main metabolic concerns are hyperkalemia, metabolic acidosis, intravascular volume overload, and maybe the bleeding. At present, there are no practical guidelines for maximum safe level of potassium prior to induction of anesthesia. There are no orderly progressive changes in the ECG with the increase in the potassium levels. So, because the increase in potassium level depends not only on the absolute level of potassium, but it is a transcellular gradient that affects the ECG changes. Whenever there is a hyperkalemia, it's better to go for hemodialysis if time permits, because 1 to 2 hours of hemodialysis is sufficient to bring the potassium levels to the safe limits. If surgery is urgent, we can't wait for the dialysis, then medical management of the potassium should be considered in the form of, as discussed previously, calcium chloride or calcium gluconate, glucose and insulin, and the sodium bicarbonate. And whenever there is potassium is more than 5.5 or ECG changes are present, succinylcholine should be avoided. Management of the intravascular volume overload. Whenever intravascular volume overload is there, then weigh risks and the benefits of delaying the surgery over the preoperative volume overload should be discussed among the surgeons, anesthesiologist, and the nephrologist. Because intravascular volume overload and pulmonary edema may be exacerbated by fluids or transfusion during surgery, and these patients might need urgent post-op dialysis or a brief period of non-invasive ventilation or controlled mechanical ventilation post-operatively. Patients who are on dialysis but have some degree of residual kidney function, they may respond to high dose of loop diuretics. In a relatively hypervolemic patient, that can occur because the excessive fluid is removed during dialysis. Intraoperative hypotension can occur because of the anesthesia-induced systemic vasodilatation and result in the complications such as thrombosis of the arteriovenous access site. If the metabolic acidosis is present, that should be managed with sodium bicarbonate 1 to 2 milliequivalents per kg, and can be repeated after 30 minutes if the pH is still less than 7.1. These patients may present with the bleeding either during the surgery or after the surgery. So treat the platelet dysfunction. IV desmopressin can be considered. If the patient is actively bleeding, platelet transfusion should be considered. But this should be remembered that platelet transfusion affects the only transient effect because these platelets are rendered dysfunctional by the uremia milieu of the patient. Intravascular access is challenging in these patients on dialysis, because especially these patients on dialysis, because these patients have already undergone various hemodialysis catheter insertions previously. Peripheral venous catheters, ideally veins on the back of the either hand are used. If these veins are inadequate and peripheral venous access is necessary more proximally in the upper limb, then dominant arm is preferred, because the non-dominant arm is usually used for the AV fistula formation. If the patient already has AV access in the upper limb, other arm should be used for peripheral venous catheters. PICC lines should be avoided in patients on dialysis. If at all required and an emergency, then tunneled PICC lines can be used. Central venous cap placement is again difficult in these patients because of previous insertions of the hemodialysis catheters. A new CBC should not be placed on the same site as the existing hemodialysis catheter. Avoid placement of the CBC in a subclavian vein because of the possibility of inducing subclavian stenosis that may preclude the subsequent creation of an AV fistula in the ipsilateral arm. And whenever inserting the CBC line, ultrasound guidance should be taken because it helps in the identification of the condition of the veins like venous thrombosis, etc., and also prevents the complications like pneumothorax and the carotid artery puncture. If patient is having already AV fistula in the arm, then meticulous care should be taken to avoid the thrombosis. That is, BP cuff measurements and the needle sticks in the limbs with fistula should be avoided. Direct pressure on the fistula should be avoided during patient positioning and throughout the perioperative period. Hemodialysis catheter, ideally a hemodialysis catheter should not be used for the purpose other than the dialysis. But if there is an emergency and alternate venous access is not possible, then this can be used. In that case, residual heparin in the catheter must be aspirated and discarded before use. Catheter must be appropriately flushed and reheprinized after the use. Similarly, for intra-arterial access and the blood pressure monitoring, ultrasound guidance should be used for selection of the potential sites for the arterial catheter insertion. Now, coming to the choice of the anesthesia, these patients may undergo local, regional, or general anesthesia. Whenever possible and feasible and appropriate for the surgery, local anesthesia with monitored anesthesia care is often selected for patients on the dialysis. Other is regional anesthesia. A regional anesthetic technique such as peripheral nerve block or neuraxial block in the form of spinal or epidural are often selected for these patients with end-stage kidney disease. These are the various drugs that are used commonly for the monitored anesthesia care, and these are like propofol, dexmedetomidine, and the ketamine, and the short-acting opioids like fentanyl and the remifentanil. Few trials have shown and compared dexmedetomidine in patients with end-stage renal failure and with the normal patients, and they found no difference in the pharmacokinetics of dexmed as compared to the normal patients. There is another meta-analysis in 2022, and 39 studies were taken this meta-analysis, and they concluded dexmed appears to have post-operative renal protective effect. This was evidenced by low NGAL levels and the increased creatinine clearance in those who received dexmed. These effects are also associated with the decrease in the ICU length of stay and risk of AKI and the mortality. So in nutshell, dexmed can be used safely in patients with end-stage renal disease. Now, what are the advantages of the regional or general anesthesia in these patients? First is avoidance of a general anesthetic and need to administer multiple IV anesthetic agents in these patients. If required, with regional and the local anesthetic technique, supplemental IV sedative, anxiolytic, or analgesic agents may be administered in small titrated doses if necessary. Another advantage is superior post-op analgesia with neuraxial or peripheral blocks with reduced requirement of systemic analgesic agents. And it also results in improved patency and lower failure rates for vascular surgical procedures to provide dialysis access in these patients. As far as disadvantages are concerned, only disadvantage is that because these patients are mostly with coagulopathy or significant bleeding diathesis, or maybe they have gone hemodialysis with heparin. So regional anesthesia techniques such as neuraxial anesthesia, paravertebral and deep plexus blocks like paravertebral and lumbar plexus blocks to be avoided in these patients. If at all necessary, then coagulation profile should be checked before putting these blocks. And at the end of the, even while removing the catheter, if we put the neuraxial anesthesia and while removing the catheter in post-op period, if the patient has undergone hemodialysis, then catheter should be removed only after checking the coagulation profile of the patient. General anesthesia. This is widely used for most of the procedures, but concerns are because metabolism and elimination of many IV anesthetic agents may be delayed in patients with end-stage kidney disease due to impairment of glomerular filtration and renal tubular function, leading to accumulation of the drugs and their metabolites. Volume of distribution and degree of plasma protein binding of the anesthetic drugs may be altered, resulting in higher than expected plasma concentration of these drugs. And effect of the hydrophilic drugs is also effect because the increase in the extravascular volume in these patients. So while giving the bolus doses, this should be taken care of. These are the various IV anesthetic agents that are used in these patients with end-stage kidney disease. Propofol is the most common induction agent of choice for most of the patients. Other options are etomidate and the ketamine. Although these two trials are old, but they have shown clearly that pharmacokinetics and the pharmacodynamics of propofol are not altered in patients with end-stage renal disease, and even hemodynamic changes are also same as in the normal patients. So propofol can be used safely in these patients. Depending upon the patient and the procedure-specific factors, etomidate and the ketamines are the other options. These are the various neuromuscular blocking agents in these patients. Neuromuscular blocking agents. If the patient requires rapid sequence induction and intubation, then succinylcholine is the drug of choice if the potassium concentration is less than 5.5. And in normal patients, if succinylcholine is given, it increases the potassium concentration from 0.5 to 1 milligrams per liter. And this hyperkalemic response is not exaggerated in patients with the end-stage kidney disease. But at the same time, it should be kept in mind that ESKD patients have reduced level of plasma choline esterase, the enzyme that metabolizes the succinylcholine. So neuromuscular block caused by succinylcholine may be prolonged. If potassium concentration is more than 5.5, then rocuronium is the option. It should be given in the dose of 1 milligram per kg in high doses. It is primarily eliminated by the liver and some extent by the kidneys, but neuromuscular block is prolonged after large dose suitable for the rapid sequence induction and the intubation. If the patient does not require rapid sequence induction and intubation, then atracurium, cis-atracurium, and are typically selected to facilitate the laryngoscopy and intubation. Both atracurium and the cis-atracurium, they are independent of the kidney function because they undergo usually Hoffman elimination and the metabolism by non-specific esterases. Cis-atracurium is the cis-atracurium, the cis isomer of the atracurium, and can also be used safely. But if the rocuronium is used in these patients, the neuromuscular monitoring must be used. Another technique is remifentanil intubation technique. A remifentanil intubation technique can be used to facilitate the laryngoscopy for patients who don't require rapid sequence induction and intubation. This can be done by using the induction with the propofol, then high dose of remifentanil, and intubating conditions can be achieved within 2 minutes. And thus neuromuscular blocking agents can be avoided. For maintenance, both inhalational or total IV anesthesia can be used. Typically, a combination of IV and the inhalational anesthesia is inhalational agents is employed. Isoflurane, sevoflurane, and desflurane may be used with or without nitrous oxide. Previously, there was a concern with sevoflurane of nephrotoxicity because of the compound A formation with the circle absorbers. But this was in animal trials, and human clinical trials are failed to prove this. So sevoflurane can be safely used in patients with stable chronic kidney disease and those on the dialysis. Uh, Total IV anesthesia is the another option using propofol and the remifentanil. And whenever muscle relaxants are used, neuromuscular monitoring should be done. For analgesia, short-acting opioids are used because pharmacokinetics and pharmacodynamics of short-acting opioids are not affected by the end-stage kidney disease. Fentanyl is it metabolized in the liver to norfentanyl, an inactive metabolite. It has short redistribution phase and its free fraction is not different in the ESKD patients compared with the without ESKD patients. So fentanyl can be used safely. Remifentanil, dose adjustment is not needed with remifentanil because it is again broken down by the non-specific plasma and tissue esterases. So it can be also used safely. But morphine should not be used because it had been converted to morphine 3 and morphine 6 glucuronide, and these are excreted by the kidney and half-life is prolonged and these metabolites are active. So they lead to CNS depression, respiratory depression, and the seizures. Similarly, tramadol and the pethidine should also be avoided because of the active metabolites and secretion by the kidney. Now, during emergence, neostigmine and sugamadex are used. Neostigmine because pharmacokinetics of single dose of this drug at the end of the surgery do not differ from the patient with normal kidney function, so can be used safely. Sugamadex can be used if there are high dose rocuronium has been used, because sugamadex is a chelating agent that encapsulates the rocuronium and vicuronium, and can be used with patients with ESKD. Sugamadex rocuronium complexes are but retained longer in the patients with ESKD than the normal patients. Clinical significance of this delay is not clear. And moreover, sugamadex rocuronium complex can also be removed by the dialysis. Now coming to fluid management in these patients, that is also very important and challenging, because hypervolemia is there that will increase the risk of pulmonary and peripheral edema, hypertension, and poor wound healing. Hypervolemia will cause hemodynamic instability and AKI. As like all other patients, crystalloids are the first line therapy. Normal saline and balanced salt solutions like ringer lactate and plasmalide can be used. But if normal saline is used in large amounts, then it can cause hyperchloremic metabolic acidosis. This can also be explained by the SID theory. Normal SID of plasma is 40 milligrams per liter and chloride is 98 to 106 milligrams per liter. But in normal saline, chloride concentration is 154 milligrams per liter. So if anion gets strong, ion difference will decrease and it will cause the acidosis, resulting in hyperchloremic metabolic acidosis. Similarly, ringer lactate and plasmalide have also got the chlorides, but in the lower range, about 117 to 127 milliequivalents per liter. And they don't cause much acidosis. And moreover, they also contain the buffers like acetate and the lactate. They are converted into bicarbonate in the body. So metabolic acidosis is not the problem with balanced salt solutions. Although the split trial, one of the trial like split trial showed no difference between the normal saline and the balanced crystalloid solutions in the incidence of AKI and the mortality in the ICU. And another trial that was done on patients with diabetic ketoacidosis for fluid resuscitation and compared plasmalide and 0.9% saline in these patients, they found better base deficit and higher bicarbonate levels and less incidence of AKI and more effects on the patients in patients who received the plasmalide rather than the saline. So in nutshell, balanced electrolyte solution did not cause hyperkalemia in clinical trials, so they can be used. But still, if the patient has hyperkalemia, normal saline can be considered, and balanced electrolyte solutions are the drugs of fluids of choice in these patients. Now coming to colloids, as far as the hydroxyethyl starch is concerned, most of the studies have shown increased incidence of AKI, renal replacement therapy, and mortality in the critically ill patients. And recent perioperative trials have compared starches with the crystalloids used for volume expansion within the goal-directed approach with mixed results. In one of the trials that included high-risk surgical patients, a higher incidence of post-operative AKI was seen in HS group, even though the comparator was saline, which itself be associated with the renal dysfunction. And that also showed increased morbidity and the increased renal dysfunction in the HS group. So starches should be avoided. Other problems like coagulopathy, accumulation of the large molecules, and renal dysfunction that initially was associated with the large molecular weight starches, but now it has been shown it is associated with the smaller tetra starches as well. So colloids in the form of starches should be avoided. If colloids are to be given, then 5% albumin is a good option. It provides nephroprotection in sepsis, maintaining the integrity of the endothelial glycocalyx, improvement in microcirculation, and anti-inflammatory properties, and also antioxidant as well. Now, question is how much fluid to be given. So again, we all, like all other patients, goal-directed fluid therapy guided through pulse pressure variation, stroke volume variation, or transesophageal echocardiography is the gold standard. Other thing, maintenance fluids are aimed at other way of maintaining the fluids are renal and the insensible losses for a positive balance of 500 ml per day or 25 to 30 ml per hour plus the previous hour's urine output can also be considered. Perioperative blood transfusion should be avoided in these patients whenever possible. However, if hemoglobin is less than 7, particularly with the ongoing surgical bleeding, transfusion of RBCs is often necessary. Target blood glucose should be less than 180 throughout the perioperative period, whether the patients are diabetic or without diabetes. If hypotension occurs in patients with the neuraxial blocks, then it should be better managed with vasopressors rather than the fluid boluses, because once the effect wears off, return of vasomotor tone will cause return of the administered fluid to the central compartment and might lead to hypervolemia. Now, coming to the post-operative management, for analgesia of these patients, multimodal analgesia should be considered in the form of wound infiltration, peripheral nerve blocks, or neuraxial blocks. And short-acting opioids like fentanyl in the form of PCA or IV infusion can be considered. Methadone and buprenorphine can also be used. Buprenorphine is non-dialysable, so even in the dialysis, its pain is consistent. Acetaminophen or the acetaminophen is other option, and ketamine can be used for more painful surgeries. In post-operative period, hemodynamics, electrolytes, ABGA, and RFT should be monitored in these patients. And if required, these patients usually may require dialysis after within 48 to 72 hours of the major surgery. Then in these patients, dialysis should be considered. And if there's a major surgery, heparin should be avoided in these patients. So to summarize, while managing these patients with end-stage kidney disease, prevent further progression of the disease and also prevent the AKI, regional anesthesia technique is preferred. No preloading with crystalloids if neuraxial block is planned. Hypotension should be managed with vasopressors rather than the fluid boluses. Balanced crystalloids are preferred over normal saline. Among colloids, albumin has been found to be safe. Goal-directed fluid therapy is the gold standard in these patients. Thank you for your patient listening. Thank you so much.
Thank you, Dr. Mamta, for letting us know the intraoperative management. I'm sure with all the knowledge that we have gained, we will be more confident when we are dealing with these patients, and we will really know what exact is our anesthetic plan, how are we going to maintain the airway, and we'll be all prepared for any complications that come. Thank you so much. And good evening, Dr. Baljit Singh, sir. I find you here.
Very good evening. I'm sorry, I was on the road, so I couldn't join
Yeah,
early.
thank you, sir, for joining, and hope you're liking the presentation.
Oh, yeah, I enjoyed Dr. Mamta's.
So our last speaker for today is Dr. Kirti Kshetrapal. Dr. Kirti Kshetrapal, she's a professor in the department, and Dr. Kirti is going to talk to us about, she's selected some interesting cases from the literature that will tell us that how we can handle these patients of chronic kidney disease. Dr. Kirti. Dr. Kirti is also an ACLS and BLS instructor. She's into doing lots of renal transplant cases. So she has interest in kidney disease patients. She even looks after them in the ICU. So Dr. Kirti, over to you.
Thank you, ma'am, for the kind words. Thanks, ICA, for the invite. Now, my topic of discussion today is my screen shared?
Yes, ma'am.
Thank you so much. So,
Yes, ma'am.
So, I'm going to discuss the interesting cases and literature review in chronic renal failure. First of all, in the recent times, there has been a lot of interest in research regarding the biomarkers, new biomarkers for chronic kidney disease. Multiple reviews have appeared in the literature. So, new biomarkers in chronic kidney disease offer improved diagnostic accuracy and insights into the disease progression compared to the traditional markers like serum creatinine. Biomarkers currently used in clinical practice are considered relevant when there is already significant impairment, thus compromising the early use of potentially successful therapeutic interventions. Early identification of CKD is important. Why? To meet the unmet medical needs, not only to predict and prevent CKD progression, but also improve patient survival and reduce associated morbidities. GFR estimation, at present, GFR estimation correlates with the degree of kidney dysfunction, while albuminuria identifies the presence of renal damage. So this is the diagram showing the new biomarkers. They will tell where exactly the renal pathology is. According to the anatomic localization, they can be the markers of renal glomerular function like BTP and B2M. These help in estimation of GFR. Then there are markers of endothelial dysfunction. They are SDMA, ADMA, and FETUN A, markers of tubular injury, kidney injury marker 1, ANGAL, NAG, liver FABP, and UMOT. Markers of inflammation, we know interleukin 6, TNF alpha, and a lot of articles are coming up regarding the metabolomic profiling, telling us the pathophysiology of the various kidney diseases like diabetic patients, what pathophysiology is going on, or other patients with severe kidney disease, what processes are going at the molecular level. Now, these are the markers which tell us about the glomerular function, out of which a lot of interest has generated for cystatin C, beta-2 microglobulin, beta-2 trace proteins. If you see the comment, they are actually increased or decreased once the before the even the GFR markers decline. So it is a very early, it takes up, it diagnoses the CKD in a very early stage. Now, for regarding the tubular injury, KIM1, NAG, and liver FABP, uromodulin, they are all being well studied. And here they tell us the proximal tubular injury very early, before even the proteinuria sets in. Then other inflammatory markers and endothelial markers. So why aren't they in routine use? Because they are still not a part of standard guidelines. Currently, use is restricted to research-linked clinics, specialty centers, or the cost and availability also limits its use. Potential role of biomarkers in anesthesia. They help in better preoperative risk stratification, like cystatin C provides a more accurate estimate of GFR than creatinine in elderly patient, malnourished or with low muscle mass. Identify patients with higher perioperative risk even when creatinine is normal. Prediction of intraoperative and postoperative kidney stress. Biomarkers like ANGAL and KIM1, if elevated preoperatively in stable CKD patients, may indicate under ongoing subclinical tubular stress or inflammation. If we know the patients are in early CKD, then even during anesthesia, the drug dosing can be tailored and choice of anesthetics can be made accordingly. It can help in what Dr. Mamta had told, the goal-directed fluid therapy, guiding intraoperative fluid and hemodynamic management. Patient with elevated ANGAL KIM1 may be at higher risk of fluid overload or hypoperfusion-related injury. They help in enhanced post-operative monitoring in whom the biomarkers are raised. We can monitor them closely, investigate them, and can have a long follow-up of these patients. Now, another interesting review article that I found was chronic kidney disease in pregnancy. It is an underestimated problem because the incidence of CKD in pregnancy is 3%. Why it becomes a point of discussion? Because physiological changes of pregnancy can increase the risk of adverse outcomes. Pathophysiology of CKD: changes in renal function in pregnancy occur. There is increased GFR and renal plasma flow. They can mask the severity of underlying CKD in early in pregnancy, making monitoring of renal function closely throughout the pregnancy very essential. Altered tubular function and anatomic changes affect the interpretation of laboratory tests, management of kidney disease in pregnant women. Impact of CKD on maternal and fetal health in the form of there is increased likelihood of developing hypertension and proteinuria during pregnancy. Preterm delivery and stillbirth are common. Further decline in maternal renal function can occur. These patients are predisposed to preeclampsia, anemia, and gestational diabetes. The likelihood of adverse outcomes predominantly depends on the baseline excretory renal function, hypertension, proteinuria, and to a lesser extent, the underlying cause of CKD. However, even women with preserved excretory renal function, that is stage 1 and stage 2 of CKD, have higher risk of complications compared to the general obstetric population. Anesthesia, consideration in women with CKD. During the preoperative assessment, stage of CKD should be identified and its underlying etiology. Need for dialysis should be identified and it should be scheduled appropriately. Physiological anemia of pregnancy is superimposed on the anemia of CKD and may require correction in the form of supplemental iron, erythropoietin, and if very necessary, red cell transfusion. Identifying and managing comorbidities is another important thing, that is hypertension, CVD, and diabetes should be evaluated in these patients. Risk stratification: patients with ESRD have a very higher mortality rate. They are at increased risk of acute kidney injury, major adverse cardiac events, and other serious complications. Preoperative optimization: crucial to optimize fluid, electrolyte, and acid-base balance to prevent complication. Adjustment should be made in dosages of renally excreted drugs to avoid adverse effects. There should always be a nephrology referral in the antenatal period. What should be the choice of anesthesia? We have to ensure both maternal and fetal safety. GA may be required in certain cases, and it should be planned meticulously and executed smoothly on the lines that has been already discussed by Dr. Mamta. Spinal anesthesia is safe and preferred technique for cesarean delivery in CKD patient. Epidural anesthesia can also be used cautiously. Risk of dural puncture and hypotension should be considered, avoided in patients with severe coagulopathy and thrombocytopenia. Regional anesthesia crucial to monitor signs of local anesthetic toxicity. Factors to be considered while giving an anesthesia is the severity of CKD and associated comorbidities, urgency and type of surgery, patient preference, contraindication to specific techniques, availability of resources and expertise. Now, monitoring and management. Fetal monitoring is essential. Careful medication dosing and maternal fetal well-being should be monitored. Fluid balance has already been discussed and reiterated, must be meticulously managed. Medication should be titrated cautiously due to altered pharmacokinetics during pregnancy. Maintaining adequate uterine perfusion, fetal oxygenation is crucial, particularly if the fetus is compromised. Now, what are the current recommendations? Anesthetic management demands a comprehensive multidisciplinary approach aimed at minimizing maternal and fetal risk. Spinal anesthesia is the preferred for cesarean delivery in CKD patient as it avoids the risks associated with general anesthesia. Epidural or combined spinal epidural can be a viable option, offering advantage of precise anesthetic titration. GA used cautiously, considering the heightened risk of hypokalemia and prolonged drug effect. Fluid management is crucial, as being reiterated. Medication must be dosed cautiously, tailored to patient's renal function, closely monitored for potential adverse effects. Normothermia and preventing acidosis are pivotal in minimizing complication. Postoperative care, vigilant monitoring of renal function, electrolytes, fluid balance to ensure optimal recovery. Women with CKD benefit from expert multidisciplinary pre-pregnancy counseling to discuss increased risk of complication and optimized management strategies. A planned early postpartum renal review is essential to monitor and address any potential exacerbation of kidney disease after delivery. Now, again, a study has evaluated the outcomes of cardiac surgery in CKD patient. They have tried to identify predictors of early and late outcomes of cardiac surgery in patients with chronic kidney disease. They found left ventricular impairment is a risk factor for perioperative and late deaths in patients with kidney disease. After cardiac surgery, preoperative dialysis-dependent and dialysis-free patients have similar long-term outcomes. Now, I know the ICA webinar on renal transplant is due in short course of time, but I would like to draw your attention to another subset of patients that are going to be on the rise in the recent future, is the anesthetic consideration in transplant recipient for non-transplant surgery. I will just give you a brief overview. Maybe it will be discussed later. Anesthesia for renal transplanted patients is an important consideration because number of transplants have increased worldwide and is increasing in our country. So we will have to anesthetize these patients who present for elective or emergency surgery, that is a non-transplant surgery. Post-transplant GFR typically deteriorates by 1.4 to 2.4 ml per minute per year. So post-renal transplant patients are considered stage 2-3 CKD when the GFR is more than 30 ml per minute. Perioperative concerns, we have to assess for graft function, graft rejection, of course, that may present symptoms of hypertension, azotemia, proteinuria, rise in creatinine. Immunosuppression and its complications have to be dealt up in the preoperative period. Corticosteroid, calcineurin inhibitors, antiproliferative medications. The patients are on these minimum three medication. Dosage regime of immunosuppressants should be noted, and immunosuppression should be continued pre and perioperatively. These subset of patients are at increased chances of infection, particularly maximum till 1 year after surgery. So the infection part should be dealt in these patients. And moreover, they are on immunosuppression that makes them more susceptible to infections. Associated comorbidities like diabetes and cardiovascular disease should be evaluated. Cardiovascular disease forms 30% of mortality in patients in the post-transplant phase. We must be very well aware of the anesthesia drugs and techniques that have already been discussed, and always ensure maintenance of the graft function in the perioperative period. Type of anesthesia, general anesthesia with renoprotective approach. Neuraxial anesthesia, spinal or epidural can be safely used in patients with renal transplant. Regional anesthesia can be used as a sole technique or along with GA for post-operative pain relief. Thank you so much for the patient listening.
Thank you, Dr. Kirti, for bringing out such interesting and important cases from the literature, which help us handle these patients with more confidence. And now we have questions in the chat box that can be answered. So the first one is that after how long, how much time period between dialysis and surgery? So maybe Dr. Anju would like to answer this.
Yes, ma'am. It was already discussed. Usually in the elective kind of surgery, if the surgery is elective, dialysis is recommended a day prior to surgery. And at least 4 to 6 hours shall be elapsed after the dialysis till we start the surgery. If the surgery is emergency kind of surgery, then the same day dialysis can be done. And if the delay after the dialysis of 4 to 6 hours is not possible, is not feasible in some dire emergency surgery, in that cases a balance must be struck between optimizing the patient and proceeding with the surgery. So risk benefit ratio must be seen before proceeding with the surgery, with the close monitoring of fluid balance and the serum electrolytes.
Yeah, thank you. So I hope the question stands answered. We have another question that blood transfusion in CKD patients in emergency. So what are the precautions to be taken? Dr. Mamta, you would like to highlight on this?
Yes, ma'am. Because these patients, CKD patients, are at high risk of developing antibodies to HLA antigens, and especially these patients when are the future candidates for the renal transplant. So for in these patients, even if the blood transfusion should be avoided, but in case of emergency, blood transfusion can be considered in the form of leukodepleted, that is removing the WBCs, and so that will decrease the formation of the antibodies and prevent the further illumination during renal transplant. So leukodepleted blood transfusions can be used in these patients. And other precautions that can be taken up, because blood transfusion will also cause the fluid overload and the hyperkalemia. So that should be monitored and corrected.
Yeah, I think some of the residents and some other participants have also put their answers and they are in the same direction. Thank you so much for the answer and answering those questions by the participants. Thank you so much. And I think that brings us to the end of the presentation. I really like to thank Dr. Jayashree Sood ma'am. And I also see my sister from Bahrain, Colonel Rita Singh, who's also joined the webinar. So, Dr. Rita, can we have your comments if you have anything to tell us? Can we have?
Yeah, hi. Thank you, Dr. Susheela and the team of distinguished speakers from the Anesthesia Department of PGMS for the wonderful and insightful ICA webinar today. I really enjoyed it, attending it. You covered the entire gamut of perioperative management of CKD patients, and thank you so much for sharing your expertise. This is very valuable knowledge that you guys have shared today, and this will undoubtedly enhance our anesthesia practice, starting from the usual standard management to what is new, biomarkers. Excellent presentations, and thank you very much.
Right. Thank you so much, Rita. Thank you so much, ma'am, to Dr. Jayashree Sood ma'am and Dr. Baljit Singh sir, that we got a chance to be on this national platform with the ICA webinars. We really had a good session and we enjoyed participating, and we look forward to many more. So over to Dr. Baljit Singh sir, maybe.
Yeah, thank you so much, Dr. Sheila. It was a pleasure listening to the two presentations that I had. Sorry I missed out the first two because I was on the road. I must say that it was Team Rohtak at its best. It was all women team in that period, more unique apart from the fact that the latest scientific literature has been presented and discussed on during this webinar. Well, I think renal disease is becoming more and more important for anesthetists because the rising number of hypertension and diabetic patients. So more and more patients are coming to the hospital for various kinds of treatments, and all those areas which the anesthesiologist must be very good at, with regard to the chronic renal disease. I think those have been taken up. Excellently moderated by Dr. Susheela Taxak, a very senior and a very learned teacher herself, and as well as a good researcher, I must say that. And I compliment Dr. Mamta Bhardwaj, on anesthesia concerns in patients with CKD, and she laid stress on the regional anesthesia and the goal-directed therapy. I think that's that's the take-home points. And Dr. Kirti Kshetrapal on the latest research, the latest thought that's there on chronic renal disease world over. I think it's very important that we must keep ourselves abreast with what is happening all around the world so that we can keep pace with them. And I'm sure the previous two presentations as well by Dr. Sudha Puhal and Dr. Anju Rani also would have gone very well, considering that Dr. Susheela is there at the top to guide the juniors. Friends, thank you so much. Congratulations to all the speakers, and we look forward to have all the speakers as well as our moderator for today, Dr. Susheela Taxak, on this platform in future as well. On behalf of the President and my own behalf, I thank all the speakers for a wonderful presentation and very nicely discussed topics. Thank you so much. And good
Thank
night.
you, Baljeet. Thank you. And I can say very confidently that Dr. Sudha and Dr. Anju did a very good show, and they covered the points so well, so that which was very clear to the students, because the other ones were, of course, the clinical follow-ups in the cases. But both the lectures were excellent. So I was there from the beginning, yes. So thank you very much, and bye-bye, and see you sometime soon.
Good
Thank
night,
you. Good
ma'am.
night.
Thank
Good
you.
night.
Thank
Good
you.
night.
Thanks, Ms.
Good night.
and Planet.
Thank you so much, everyone, for joining this
Thanks,
session.
Rimpa.
It
Thank
was
you,
a very
Vinny.
wonderful session. So, with all your permission, I'm closing the session for today. Thank you so much,
Yes.
everyone.
Yes, Rimpa. Yes.
Good
Yes.
night.
Thank you so much.
Good night, ma'am.
Good night.
Good night, sir.